So thanks everybody for joining us today and welcome. Just a quick reminder to keep your microphones on mute. There will be an opportunity for questions at the end of our presentations today. Just feel free to type in any questions as we go along in the chat, and we will get to them once the presentations are complete. There is a short evaluation for this event, and we will put the link and the QR code in the chat so that you will have an opportunity to click on it. It just takes a couple of minutes. It'll also be located on the Northwestern Ontario website where this webinar information is settled. We are recording this and we would be posting it to the Northwestern Ontario website as well to the Northeastern Ontario Stroke Network YouTube channel following the presentation today, so you can find it there. I'm going to quickly introduce our two speakers today. Our first speaker is Brett Kakamo, who's a fourth-year medical student at the Northern Ontario School of Medicine, the Thunder Bay campus. Brett grew up in Thunder Bay, and before attending medical school, he worked as a stroke nurse at Northwestern Ontario's Regional Acute Stroke Unit. Brett continued his interest in neurology throughout his medical education, completing electives in Thunder Bay, and currently is finishing an elective in stroke neurology at Health Sciences North in Sudbury. Brett is applying to Canadian neurology residency in the coming months. And our second speaker is Dr. Ravinderjeet Singh, who is a stroke neurologist at Health Sciences North in Sudbury and is the medical director at the Northeastern Ontario Stroke Network. As well, he's an assistant professor at the Northern Ontario School of Medicine. He completed his medical school and neurology training in India. He did a one-year stroke fellowship in India before moving to Calgary, where he completed his two-year vascular neurology fellowship at the University of Calgary. He has a strong interest in studying the role of brain eloquence in stroke prognosis. He is also passionate about studying long-term outcomes after stroke, cerebral collateral imaging, and symptom imaging correlation in cerebral venous sinus thrombosis. Welcome to both our speakers, and I'll have Brett start us off today.
Sounds good. Thank you, Sue, for the introduction. So just to confirm, you guys can see my slides and hear me okay?
Yes, it's good.
Awesome. All right, so just a little introduction to the session. I'm going to start the first half of the session talking about a case presentation, non-stroke related, about a patient of Dr. Hassan's in Thunder Bay. And then after that, Dr. Singh is going to talk about TIA management in the emergency department. So both should split around half. And I'll have some time for questions at the end as well if anyone has any questions pertaining to the case. So the learning objectives of this presentation would be identify different presentations of encephalitis, describe the relevant radiological findings, define the criteria for diagnosis of encephalitis, and also talk about the current literature about encephalitis overlap with alternative diagnoses. So the demographics of the patient that I'm going to present is a 44-year-old right-handed female who lives in a small town in Northwestern Ontario and works as a teacher. She lives with her common law partner and has two sons that live with her. Past medical history, dyslipidemia, reactive depression, menorrhagia, congenital hip dysplasia, some ovarian cysts. Social history is notable for occasional alcohol use, half a pack cigarette smoking per day, daily marijuana use, and she does have a family history of MS. So I think the important things to note about this demographics of this patient is that she has a few vascular risk factors, notably dyslipidemia along with cigarette smoking. She has a family history of MS, and she also has a history of reactive depression. So the case presentation begins in December of 2021, where she, along with her partner, noticed some changes with her mood and her cognition. She had an initial depressive episode around 2 years ago, and she was started on bupropion at that time. After things settled, she remained off this medication and hadn't had any particularly eventful mental health concerns since that time. I'm going to introduce this kind of timeline of symptoms and the differential diagnosis at the point in time. So low mood, some cognitive changes, and at this point, there isn't anything to suggest any primary neurological disease. In February of 2022, her depression worsened, and she was admitted to her local hospital for suicidal ideation and plans to hang herself. This was a brief admission, and it ended with increase in community support, but no new medication prescriptions. Interestingly, sometime in February, she also developed impaired vision in her left eye. She was seen by ophthalmology and was diagnosed with possible optic neuritis, and an MRI head was ordered. So at this point, I'll ask Dr. Kiwan to share the images from February of 2022.
Can you see the images? Okay, good. So this MRI from February of 2022, as Brett mentioned, so starting with the flare sequence, and this sequence demonstrate multiple areas of flare high signal intensity. These lesions predominantly distributed in the deep white matter and periventricular white matter of both cerebral hemispheres, and extending down into the temporal horns of both cerebral hemispheres, where we have most of the involvement. We don't have any infratentorial lesions within the brainstem or cerebellum. And looking at these lesions in another view, which is the sagittal flare proton density view, we can see these lesions have a very perpendicular appearance to the corpus callosum, callosociptal lesions, and lesions involving the corpus callosum itself, giving the appearance of a Dawson finger appearance on the sagittal view. And when we look in this MRI in more sequences where we have the contrast sequence, and I have on the top of the screen is the sagittal T1 pre-contrast, and then the bottom is the post-contrast. And while we scrolling from down, we can start see that there are lesions which is enhancing in the periventricular in the left temporal lobe, and going more up, we start to see these lesions also another enhancing lesion, multiple enhancing lesions high up at the level of the corona radiata. So these lesions enhancing in a solid pattern uh, in both cerebral hemispheres. At the same time, we have the orbital sequences that was performed, and we can see here on the coronal T2 fat sat of the orbit that looking at the optic nerve on the left side, where it is swollen, asymmetrically enlarged compared to the contralateral side, and that's abnormality confined to the intraorbital segment. Then when we go back to the level of the optic chiasm, which looks symmetric to the contralateral, and on the post contrast from the same scan for the orbit, is the post contrast, we can see the enhancement of that segment, which is nicely seen on this sequence with no involvement of the optic chiasm. So that's the MRI from February in summary, showing multiple lesions, deep white matter, periventricular white matter with involvement of the temporal, mesial temporal lobes bilaterally. Multiple of these lesions are enhancing, and involvement of the left optic nerve in the intraorbital segment.
All right, thank you. So basically, at this point in time, after the images have been shared, thank you, Dr. Kiwan, we have a 44-year-old female with 2-month history of worsening mood and some cognitive changes, along with some symptoms of optic neuritis and MRI concerning for multiple areas of demyelination, query multiple sclerosis. So in March is when things start to get interesting with this presentation. So she again presented to her home hospital and was subsequently transferred to Thunder Bay for worsening altered mental status for approximately a week. Her father had passed away the week prior, and she started to develop some confusion around this significant event in her life. She was forgetting her age, forgetting the year, asking many numerical questions, And when they were driving to the funeral, she was not sure where they were going or why they were going anywhere. Her mood had been reported to have been stable before this decline. So obviously family was quite worried about these new symptoms. She was transferred to Thunder Bay and admitted under CTU. The current diagnosis was altered level of consciousness, and the historical MRI evidence queried any MS involvement. There was a psychiatry and neurology consult. A repeat MRI was ordered, and there was also a confirmed concern for infectious etiology. So she was started on some antibiotics, and a pending LP results were also there. So this is the psychiatry assessment. It's notable for facial asymmetry, twitching of her leg, some akesthesia, loud speech, slurred, dysarthric. She was sad, angry, labile, irritable, agitated. Her thought process was very disorganized. She did admit to having some visual and auditory hallucinations, although she did not describe these in detail. Overall, she was confused, not orientated. The psychiatry impression was that this was a delirium related to a neurological condition rather than a primary psychiatric condition. It does not appear to be a depressive episode. The neurology assessment showed that she is disorientated with significant impairment to her memory. There was notable right upper motor facial droop and significant arm weakness as well. There was no other focal neurological deficits found other than the dramatic cognitive changes. The neuroimpression at this point was an encephalitis. Unclear whether there's any limbic involvement pre-imaging or infective, autoimmune, plus or minus this multiple sclerosis piece that obviously has the historical MRI evidence. Neuro suggested the lumbar puncture be tested for cells, oligoclonal bands, paraneoplastic panel, along with meningitis and encephalitis panel. An EEG was ordered, and then also CT abdomen chest to rule out for any malignancy. ID was to be contacted about prophylactic methylprednisolone. So this is the current kind of development of symptoms and what's on the differential at this point. So talking about some neuropsychiatric changes in autoimmune encephalitis, this study really defined the different types of autoimmune encephalitis and their associated changes from a psychiatry point of view. These were the broad definitions of what we would expect someone to experience in terms of their neuropsychiatric changes in autoimmune encephalitis. Disorientation, cognitive and memory dysfunction, some behavior abnormalities, psychosis, mood dysfunction, anxiety, obsessive compulsive behavior, catatonia, and also sleeping dysfunction. So it's clear that our patient is definitely exhibiting some of these signs and symptoms that may be more consistent with an autoimmune encephalitis. So now I'm going to invite Dr. Kiwana back to review the MRI from April 4th.
Okay, thanks, Brett. So for MRI from April 4th, you can see the images. Okay, good. I see some hits. So this is the flare sequence again on the screen showing that we have definitely new lesions. This is the biggest lesion, around 4 cm lesion seen in the left frontal lobe. And in addition to that, we have significant worsening of the other lesions around the periventricular white matter. This is new lesions that around the third ventricles. It's all confluent areas, and more noticeable when we look at the temporal lobes bilaterally, we have significant involvement of the mesial temporal lobes bilaterally involving the limbic system, which was not seen. And just like to refresh our eyes with the February MRI, we can see this is the February, how it was looking and how it's looking in the recent MRI. So we have significant worsening with new abnormal signal intensity. And when we look at the April MRI for other sequences, which is such as the post contrast sequence, that this is the post contrast in the April. So this lesion, which is the largest lesion, does not demonstrate any enhancement, and mostly, like we were worried at the beginning, the main differential diagnosis as multiple sclerosis. Usually active MS lesions demonstrate some kind of ring pattern of enhancement, but none of these lesions are enhancing. And even the enhancing lesions that we saw in the February MRI, it's not enhancing on this MRI. And at the same time, there is a total spine MRI that demonstrate no any evidence of spine involvement or any lesions in the spine. So from imaging point of view, at this point, we have either worsening of her primary condition, multiple sclerosis, with new demyelinating lesions, dissemination in time and in space for this lady. At the same time, we think about involvement of the limbic system bilaterally, mesial temporal lobe. Even if it is not enhancing, we start to think about a picture of encephalitis with the predominant involvement of the limbic system. And the more confusing thing is this involvement of the white matter along the third ventricle, a little bit in the periaqueductal gray matter. At this point, like, we start to think in the NMO category of lesions, but it's not the typical with unilateral involvement of the optic nerve, and there is no any spine involvement.
All right, thanks again, Dr. Kiwan. So here we see our graph again and how the symptoms have developed and what's currently on our differential. So we know we have the historic diagnosis of possible MS, but now with the recent MRI changes, the encephalitis picture comes into play. So the EEG reading showed that it was an abnormal recording. There was an asymmetry and increase in regular medium amplitude in the left hemisphere, especially in the left temporal lobe. There's activity in the right hemisphere irregularly as well. Overall, it was a generalized process with greater effect in the left temporal region, which will be important when we talk about the diagnostic criteria. So the LP resulted, and the notable thing to mention here is that it was positive on PCR for HSV. So this individual was diagnosed with HSV encephalitis. So the three current differentials would be some sort of limbic encephalitis. It would be supported by the neuropsychiatric features, some of the MRI findings, the EEG suggesting limbic involvement. However, at this point, there was no confirmed lumbar puncture results, and the subacute presentation of these neuropsychiatric symptoms would also favor some sort of autoimmune limbic encephalitis. HSV encephalitis is confirmed by LP on PCR, but it may not explain the extensive limbic involvement and also the subacute onset of symptoms as well, where we would expect a much more rapid development of this sort of infectious encephalitis. And then obviously the MS, which we have described extensively, these historical lesions, and also the MRI findings consistent with some demyelinating features. So I think it's important to take a look about the clinical approach to diagnosing these autoimmune encephalitis. As part of one of the Lancet recent articles, some of the biggest names in infectious and autoimmune encephalitis developed some criteria on how to diagnose these. So a definitive diagnosis of autoimmune encephalitis can be made when it is a subacute onset, which our patient would have, of these working memory deficits, psychiatric symptoms that would suggest limbic involvement, limbic localization, bilateral brain abnormalities on T2, highly restricted to the medial temporal lobes. While this person did demonstrate to have medial temporal lobe involvement, the historical diagnosis of the MS, along with the demyelinating features throughout the brain, makes this particular feature of this diagnosis difficult because it's not restricted to the temporal lobes. You need one of the following, the CSF pleocytosis or an EEG suggesting involvement of the temporal lobes, which this patient had, and a reasonable exclusion of alternative causes. Her CT scan was complete and it didn't show any malignancy. So the treatment that this patient was started on was acyclovir, the antiviral, along with IV methylprednisolone. She was ended up getting discharged with improvement of the acyclovir and the methylprednisolone, and she discharged home with a mild facial droop, memory impairment, but no ongoing major neuropsychiatric symptoms. However, the final diagnosis was unclear at the time of discharge, although she did improve quite significantly. Following her discharge, the results from the LP resulted as we send our results to London, and she was found to have anti-NMDA receptor antibody was positive. So this individual had HSV encephalitis confirmed on PCR, the historical diagnosis of MS, and was also found to have NMDA receptor antibody encephalitis. The question of this case becomes, which three of these diagnoses relate to one another, or perhaps are they all existing separately? And that's where, the important piece of this case is looking into whether or not there's any historical data suggesting any of these three entities are related. And this is another one of the approaches to NMDA receptor encephalitis. And this patient would meet most of the criteria required as defined by this article in The Lancet. So here's our timeline of symptoms with the confirmed HSV encephalitis and confirmed anti-NMDR encephalitis. So it's important, I think, to look at how these two entities are related. And we can start with HSV encephalitis and NMDA receptor encephalitis. So both are relatively common on their own, but their co-occurrence questions whether or not these two entities can be related. There is evidence in the literature to suggest they are. A study in 2012 detected these antibodies of NMDR in up to 11% of a small series of patients who have previously found to have HSV encephalitis diagnosed on PCR. A study in 2013 actually looked prospectively and found that individuals that weren't positive to anti-NMDR receptor antibodies with an HSV encephalitis within 48 hours were found to have anti-NMDR receptor antibody positive following this 48 hours, suggesting that perhaps HSV encephalitis puts individuals at risk for developing these antibodies. Obviously, there's interest in their relation together to guide investigations and also the role of immunotherapy as described in a few of the studies. The next question is this autoimmune encephalitis and multiple sclerosis related? So one literature review found 9 cases reported in the literature that found that these two entities coexist, but their link is quite undetermined at this point. There is a hypothesis that the inflammatory demyelination may be a trigger for this autoimmune disease. However, the mechanisms by which MS give rise to this NMDR encephalitis is unclear. Another hypothesis of these two existing together is that maybe the role of immunosuppression in MS treatment plays a role in the development of these antibodies. Obviously, these hypotheses have not been tested, and obviously in our patient as well, she was not on treatment for MS, so this couldn't be a fitting hypothesis for the development of her symptoms. Finally, to come full circle, the relationship between HSV encephalitis and multiple sclerosis, there's no documented literature on a causality link, but we know that any infection predisposes individuals to more severe flares and perhaps more earlier onset first clinical symptoms of MS. But there are some studies suggesting that HSV encephalitis may worsen relapses in MS presentations and predispose to earlier onset of the disease. So in summary, this case was an individual who presented with some encompassing neuropsychiatric symptoms and findings on the MRI to found to be diagnosed with HSV encephalitis, anti-NMDA encephalitis, and also probable MS. There's yet to be a case reported in the literature that we found that would suggest the occurrence of these three entities together. But as I've described, 2 entities out of the 3 have been described to co-occur together, and their relationship has yet to be defined. So this is an interesting presentation that Dr. Hassan included me on to present in this presentation. Next steps, we do plan to present a case report or write a case report on this patient to publish it and to see if there's any future cases as such, and hopefully contribute to literature trying to define these separate entities. So at this time, we have a few minutes before Dr. Singh presents to ask any questions. We'll also invite Dr. Hassan if you have anything relevant to add to the case or any thoughts as well.
The only thing I would add is oligoclonal was not done, unfortunately, in the CSF. So probably we'll ask for it, but the problem is it may be positive with MS and also with autoimmune encephalitis. So probably it's not very good positive, but if it's negative, then we have to scratch our head and think of something different. I'm not sure if there is any psychiatrist or someone with background in psychiatry is on to comment on the psychiatric or behavioral aspect of this presentation.
Doesn't seem like there is. If somebody has a question, feel free to unmute or type it in the chat. We'd be happy to ask on your behalf. As well, if you add them while we continue on with the presentation, we will get to them at the end as well. We'll have a few minutes for an open discussion. Thank you very much, Brett and Dr. Kwan and Dr. Hassan, for a really interesting case. And we'll move over now to Dr. Singh.
Thank you, Sue. And am I audible? Can people hear me?
Yes, just waiting for presentation mode.
Perfect. Okay.
Perfect.
Okay, excellent. So thank you, Sue, for the kind introduction. And I would give all credit to Dr. Hassan for this brilliant idea of having this combined Sudbury and like East and the West, North presenting together. I think it's a good platform to start having some more future educational events, and we are working on the grand rounds. So I think this is probably the first or the inaugural of many more to come in future in a more regular fashion. So thank you, Dr. Hassan. So my task is to kind of more speak on the TIA, and we found that it was of interest to our physicians working in primary care and also emergency care, because this is a topic which frequently comes across as far as the patients are concerned, and I'll be showing some data. And again, the idea is to make it simple and reduce the complexity. So when we are trying to reduce the complexity, of course, I'll be missing some details, and that purposely I did it to kind of cater to a larger physician group rather than introduce complexity and make it more neurologist centric. So there will be a lot of questions because there might be a lot of individual patients which may not be captured in this algorithm. So the objective is to review the definition of TIA and when to suspect TIA, when to call a neurological event a TIA, review focus history and physical exam in a suspected TIA patients, discuss some of the initial investigation which needs to be done after a TIA, and describe some general approach how to manage. And there's a lot of personal touch, although most of what I'm presenting today is guided by the best practice recommendations, but there are other literature which I'll be showing support some of the other nuances which I'll be discussing. So here are my disclosures. So I don't have to really emphasize the fact that TIA and stroke is common, irrespective of in what setting you practice, whether it's the emergency setting or primary care or in hospital. And every year there are about 62,000 people with TI and stroke treated in Canadian hospital. And this is probably tip of the iceberg because there are a lot more patients who are treated by the primary care and some patients who never present to the hospital. And knowing these presentations are important because these opportunities could lead to missed opportunity to treat and prevent a major stroke. And we do know that once the stroke happens, it carries a major, not only economic impact, but also a lot of repercussion in terms of the patient outcome, including leading to mortality and poor functional outcomes. So the what is most interesting is that although this is a common disease, in many cases it can be preceded by a warning event, which is a TIA. And most important is that once you diagnose, treating a TIA can reduce the future risk stroke by as much as 70 to 80%, and maybe even more, by simple treatment approach. And it's not based on any sophisticated investigating algorithms or any expensive treatment. A simple approach can have a huge impact in terms of reducing the stroke risk after a TIA. And this is just to give you how common the transient neurological symptoms are. So almost half of the population at some point in their life had one or more of these transient neurological symptoms. So this is one of the important study which showed that almost 46% of the patients described one of these transient symptoms. And you can see one of the commonest symptom was a numbness or tingling, which is a sensory symptom, or dizziness or imbalance, which also has a least likelihood of being secondary to TI. So therefore, not all transient symptoms are transient ischemic attacks. And the idea is to figure out what then is the TI among all these transient neurological symptoms. Now, in the past, the emphasis was on the clinical piece. And WHO in 1988, which was the landmark TI definition, which we have been using over decades, defined as that the onset should be rapid, and it should be, of course, a neurological dysfunction. It could be focal or global and should last less than 24 hours with no apparent non-vascular cause. So that was the key themes, that it should be acute in onset, it should be neurological dysfunction, should last less than 24 hours with no competing explanation. What we now know is that this definition may not be the most appropriate definition when we current in the current era. And so in 2009, there was an attempt to revise this, and now it says it's a transient episode of neurological dysfunction caused by focal brain, spinal cord, or retinal ischemia without acute infarction. So there are now two pieces to it. One is the clinical piece, and second is the imaging piece, where there's no infarct present to explain these transient symptoms. And what is interesting is that a stroke or infarct can lead to transient symptoms. On the other hand, the transient symptoms, in the presence of transient symptom, a lot of patients might have an underlying infarct. And this is one such study which looked at it, that based on how long the symptom lasts, if you do MRI on everybody coming with transient symptoms, depending upon how long the episode lasted, the likelihood having an infarct present could range anywhere between 30 to almost 50%. And so the longer the episode takes to resolve, the more likelihood they will find a stroke. So even under 24 hours, almost half of the patients, they do have evidence of a small infarct on their scan. So I think that's important. And now these patients are classified as a minor stroke rather than a TIA. And although in some of the studies, they still focused on the time duration, but once you have a presence of infarct, you can reclassify these patients to minor stroke population. So that's something new in the definition piece. So when do you really suspect and what to really ask? So those are the two important pieces in the history. One is how the episode is. So we need to get a detailed account of the episode. And the second is what are the predispositions. And so in the history, I think we need to fulfill the definition of TI. So therefore, we need to know the onset. Was it sudden or not? The second is the semiology piece, because we want to confirm these are actually neurological symptoms, which are focal. And the third, you want to know if they are cerebral or retinal in origin. So there's some degree of localization which needs to be present. And you can also ask for associated symptoms like pain, non-localizing symptoms, or systemic symptoms, although they may not add to the diagnosis piece, it might be helpful in terms of the etiology piece. And also, it is important to know if there is any obvious trigger. There are some interesting entities which can be triggered by certain activity, like Bow-Hunter syndrome, which is because of the vertebral artery compression, and many others. So apart from the episode history, the second piece is the predisposition. Of course, the most important predisposition for TIA is a preceding history of TIA or stroke, which is the most important marker. And then, is there any history of other vascular beds having ischemic events, whether it's angina MI or claudication ischemic ulcers, or if the patient already has established vascular disease, which makes the patient higher risk. Therefore, our likelihood saying this event as a true TIA becomes higher. And you also want to know the risk factors, which is helpful not only to say this is a higher likelihood TIA event, but also determining the etiology. And in the social and the family history, I think these three pieces are most people are already aware of. And it's also important to know what medication patients were taking, because sometimes you might contemplate that, is it a medication failure? And many times you will realize that patient is not on the right medication doses, or even the choice of medication is not appropriate. Therefore, that history is also relevant. And so this I would probably spend a little more time on this slide because we now know that the transient neurological symptoms could be TIA, but what are the typical symptoms we look for? So there are 6 categories of symptoms which we generally define could be possibly TIA in nature. So you have motor dysfunction, and that is defined as weakness, paralysis, or clumsiness. The sensory dysfunction, which is a numbness, loss of sensation, or paresthesia. The speech or language involvement, which is as defined and difficulty in speaking, right? It's basically verbal versus nonverbal domain. Visual loss, which could be either monoocular, one eye, or a field loss. There could be a change in balance or equilibrium. And brainstem symptom, which is a combination of those Ds, diplopia, dysphagia, dysarthria, and dizziness, which is a vertigo piece. So if patient has these 6 set of symptoms in any combination, and which has acute onset, you can confidently say this is likely a TIA event in all probability, although there are a few exceptions. And and I'll be describing some more. I see that there in the chat there was a question about March effect. The March effect is it's basically a marching phenomena. So let's say a symptom, sensory symptom, numbness starts in the left hand, or a paresthesia or tingling starts in the left hand, involving some of the fingers, and then it gradually spreads along that arm to the shoulder, and then goes into the neck, goes to the face. So this is a gradual spread of the sensory symptom, is caused as a March effect. It can also happen in motor domain, where patient might have some twitching in the fingers, then twitching in the entire limb, and then twitching on the entire half. So when you have this marching effect, the likelihood that this is actually a TIA is less. And the reason for that is you are more thinking now more of an electrical event like a seizure or a migraine event, rather than a clot where we would expect no march but a direct involvement or concurrent involvement of all the segments which are involved. And so therefore, if you see that there is a march of the symptom from one body region to another body region, so from one extremity to the another extremity, or one arm to the facial, then you should start suspecting that if the explanation could be non-ischemic and therefore non-TIA. And so once you say once you determine the domain, the second point is it carotid or vertebral? Is it anterior circulation or posterior? And I think this domain, the domains remain the same, all those 6 set of symptoms, but in different combination, looks or localized to different circulations. So for example, if the motor dysfunction is happening only on one side, the likelihood of this is coming from the carotid circulation is higher. But if you have involvement of the bilateral side in any combination, it could be one arm with the other leg, or it could be bilateral, on one episode there was right-sided weakness, on that episode left-sided weakness. When you have this combination of bilaterality, then it is more likely posterior circulation. The same thing goes into the sensory symptom. And the speech and language, the language piece is highly suggestive of carotid circulation because the more of a cortical symptom. The speech may be anterior or posterior circulation. In the posterior circulation, of course, all the Ds, which are brainstem symptoms, are highly suggestive, especially when they occur in combination. So if somebody has diplopia with dysphagia, highly suggestive of brainstem localization. And you can also have gait involvement because of the cerebellar dysfunction. And the visual field loss are very different in the anterior and posterior circulation. In anterior supplied by the carotid, you have one eye vision loss, while in case of posterior circulation, because it's occipital lobe, it's a visual field loss. So that important information might give you an idea whether you're talking about anterior versus posterior circulation. So if you see the cerebral events, all these could be cerebral events. And they can localize to anterior or posterior circulation. In case of retinal event, there is only monoocular vision loss. So I think this table gives you a summary of all these set of symptoms which are helpful to ask for, and they are also helpful in terms of risk stratifying patient, which I'll be showing later. So what if those are the typical symptoms? What is not typical are these set of symptoms. And basically, there are many symptoms, almost 14 symptoms, but they can be categorized into 3 discrete groups. The first group is a non-focal cohort. So where a patient has dizziness, wooziness, or loss of consciousness. Now, again, I'm simplifying it because there are situations where in TIA, there could be loss of consciousness. But in general, if you have patient losing consciousness and did not have any other of the typical symptom, likelihood of that being TI is quite low. Same thing for other symptoms which I mentioned here: amnesia, confusion, bladder bowel incontinence. Usually that's not typically seen in TI. When the symptoms are isolated, so if you have vertigo alone, if you have diplopia alone, if you have dysphagia alone, so when they are isolated symptom, the chances there because of the TIA becomes lower. And finally, if you have a lot of this additional atypical symptom where a positive motor symptom like tonic activity or clonic activity, person is twitching on one side or having a lot of paresthesias or tingling sensations, especially when they are marching, may not be suggestive of TIA. And actually, it's a more of a mimic feature. And so once you say this, what is typical, what is non-typical, that kind of helps you determining. Now, this is just to show some literature saying many of these symptoms can still happen in TI. So, but again, the idea is to simplify because at the end, otherwise, it'll be hard to tease apart. And moreover, in those settings where you're not sure, it's always nice to give a call to colleague or a neurologist in those settings. But the idea is to minimize calling frequently, which I see, looks like it is seems to be a major challenge in some of our regions. And the second piece is once you took this historical piece, you suspected now what to examine. And I think the key area is there's a lot to examine, but if we can focus on the heart, neck, blood pressure, and the pulse, those are the 4 key things in these patients. And this I've just shown what they reflect actually, or what they give an suggestion of. From the neurology piece, it's a fairly standardized and a screening neuro exam. With the focus on mental status, especially the consciousness orientation, speech, language, cranial nerves. You can also have a look at the fundus if you're comfortable looking at the Horner's is important. So if there's any ptosis with the meiosis or pupillary symmetry, that gives you an idea about the etiology at times. And limb examination, which is basically more a sensory coordination and gait and balance, which is important from the safety side of it. And so once you examine the patient, how to investigate, that depends on the setting where you are in. So let's say you are in a primary care setting. So then you will have to determine if to send this patient to emerge or not. If you're already in an emergency physician who is seeing a patient, then this will be in the algorithm. Now, if you're in a community practice, you want to refer the patient, we were using this a little more complex strategy in the past, which has now been simplified in the best practice recommendation. What it says is if you're suspecting a TIA or acute stroke event, especially if there's a transient focal motor or sense speech symptom or persistent stroke symptoms, and if they happen in the last 48 hours, send to ED. If they happen beyond 48 hours, patient needs assessment, as quickly as possible. Now, that could be referring to a local stroke prevention clinic or to the local emergency department, depending upon where you are in Northern Ontario. And so in most cases, in our district, these patients are referred to us. And why this is important is because the window of opportunity is small, and moreover, the chances that these patients, if we have a missed opportunity, there's a high likelihood many of these patients will come back to emerge either with a stroke or another cardiovascular event. And you can see even in the next 90 days that chances of mortality is also significant. There are some predictors which are now captured in the California score or ABCD2 score. They are fairly similar, and I'll be showing that as well. So basically, it's the age, the demographic of the patient, some of the risk factor, and how the episode looks like. That gives you an idea how the episode, what is the risk of future event. And so the next point is that if you are emergency physician, so from the primary care, you have referred to emerge, and now the emerge doc is seeing the patient. So what should he or she order for? The minimum is doing a CT of the head and a CT angiogram. The CT of the head is basically to rule out hemorrhage. It can also show you the clot, can also show you the infarct. On the CT angiogram, it can show you the clot, and it can show you the etiology in many cases, because almost 2/3 of the cases of TIA are non-cardiogenic in nature, and most of the time they are related to the large arterial disease. Therefore, it's important to get a vascular imaging early. So for us, the NCCT and the CT angiogram is an ECG and troponin. So for a patient with chest pain, we always make sure those two things are done. In a patient with TI, we always make sure those two pieces are done. And now, why this is, there's a fantastic literature and a large study which was published in New England Journal. What it shows is that if you have multiple infarcts on CT, or you have a presence of large artery disease, both of which predicts a very high likelihood of having further recurrent stroke rate. So therefore, those are the two big pieces we want to capture early on to risk stratify our patient. And what else can you do in ED? And again, there are a lot of things can be done, but I think the basic panel is fairly standard. If you can send a glycated hemoglobin lipid profile, that's fantastic. But again, if you have a good support from the stroke prevention clinic, most of these could be done there. But having a CBC random glucose coags, but a kidney function because you're giving contrast, electrolytes, and tropes are relevant. And the ECG should be done as part of the initial workup. The echoes can be ordered from Emerge or can be arranged in the stroke prevention clinic, again, depending upon the setting where you work. This is in terms of the management. Once you have done the initial workup, now you're ready to treat the patient. And so what are the key things? And again, I have simplified it to make it a very algorithm based. Of course, then you start losing the details, but I would say in most settings, this holds true, and you can safely use this and start, practice this if you find it helpful. So the idea is to first suspect TIA. The first decision point is this a TIA or not? And based on the initial strategy, which we discussed about what is the typical symptom, what is the atypical symptom, you can say whether it's more of a mimic or a true TIA. Once you say this is TIA, the first decision point is, do you have history to support cardioembolic source, high-risk cardioembolic source? So which could be that patient is now in AFib or has history of AFib and currently not on anticoagulant, or a patient is known to have high-risk cardioembolic source like a severe mitral stenosis and currently not on anticoagulation. So if the cardiac history is supportive, then, and it is only for the high-risk cardioembolic source, not any cardiac comorbidity, then you can start the patient on oral anticoagulation if already not started, if there's no contraindication. In minor stroke, you might have to weigh in based on the stroke severity and the infarct size, and I'm happy to discuss that later. But for the TIA population, you can start on day one. If it is not a high-risk cardiac source, then you are likely dealing with a non-cardioembolic TIA, and therefore you can use a risk score. Now, there are people do use different risk scores. The standard is ABCD2 score. If you have a score of 4 or more, so for example, if you have a patient with 70 years old, which gets a 1 point, had a speech and motor symptom, which you get 3 points, you're already at poor score, and therefore high risk. You can load this patient with dual antiplatelet with aspirin 160 and Plavix either 300 or 600, depending upon which trial results you're using. Either is fine. And followed by maintenance therapy with aspirin 81 and Plavix 75 if no contraindication. And depending upon how you further want to continue this dual antiplatelet therapy will depend on the results of the CTA. And also in both populations, whether cardioembolic or non-cardioembolic, you can start high-intensity statins, which have shown to lower the stroke risk by almost 25 to 30%, independent of their antithrombotic use. And the results of the CTA will determine how you're going to go further with the antiplatelet therapy. If the carotid stenosis is present, you urgently refer for carotid revasc. Until that time, patient continues on dual antiplatelet. And again, ideally, we want to treat them under 2 weeks, but sometimes there could be a delay. So therefore, they should stay on dual antiplatelet therapy till then. If the patient has symptomatic ICAD, so if there's a severe stenosis of the intracranial arteries, then the patient should stay, instead of 3 weeks, should be on 3 months of dual antiplatelet. And if there's no large artery atherosclerosis, you can, after 3 weeks, you can switch the patient to single antiplatelet. And so this is, again, very simple algorithm. And the only other piece which I want to capture is if the risk score is low, it's kind of partly depends on your practice. Sometimes I might still use, depending upon my CTA results, I might still use the dual antiplatelet approach. But in other settings, you can still use single antiplatelet because these patients were typically not enrolled in the clinical trials. So once you started the patient on the treatment with one of those strategies, then how are you going to further go? Are you going to admit the patient or are you going to discharge from ED? So if you're admitting, these are some of the general guidelines. And again, this is just to inform, and it might depend in your setting whether you want to proceed or use this or not. So if there's a significant deficit, there's no question you need to, because patient is now having a stroke, not a TIA. If the gait is unsafe, again, chances of that there is underlying infarct becomes higher. And moreover, you don't want to discharge the patient because of risk of fall. High-risk etiology. So again, depending upon the access to carotid or your vascular surgery team, sometimes it is better to admit a patient with carotid stenosis or high-risk etiology to have more immediate access to the consult service. And high-risk features, including severe comorbidities. If you see a patient with a severe uncontrolled hypertension, you don't want to just start the patient on dual antiplatelet and send home. In these cases, you might admit the patient and make sure it could be a short admission, but it might be helpful in this setting. And if you're not sure, then either admit or ask a neurologist in that setting. If you're discharging from the emergency department, make sure that there is an appropriate imaging done, which we just discussed, minimum CT-CTA and ECG and minimum blood work. And patient is started on the appropriate antithrombotic therapy. Either it could be anticoagulation based or antiplatelet based, which we just discussed, and the initial treatment for the risk factor. And make sure that the patient is referred to the appropriate stroke prevention clinic where they can go for further workup and management. And so this is our stroke prevention clinic referral form. Again, it captures mainly the triage piece. So if you are in the emergency setting, this is what you're supposed to do. If you are in the community setting, what you are supposed to do in terms of sending to the emerge. And it also mentioned what medications were started. It's just to provide a kind of an option so that people look at it and then before checking off, they make sure that that is done. And so now I have some of the cases. So we have about 6 more minutes. So there are 3 cases, but I can stop early if the time does not permit. So I'm just going to show one case and then we'll start discussing. So this is a 52-year-old male with history of hypertension, chronic smoking, had 4 episodes of left eye transient vision loss. So again, to emphasize, this is a left eye vision loss. So it's a monocular vision loss in the last 1 month. Examination was fairly normal. And so again, we don't have an option for poll, so you can write it down for yourself and self-assess. So what would you do if you are in the emergency department? So based on that history, are you going to just start antiplatelet and send the patient home? 2, do a CT head and start antiplatelet therapy. 3, do a CT head with a carotid Doppler. And 4, do a CT head with CTARs to Vertex. And again, we can come back later. And so again, just to highlight, based on the algorithm which I initially suggested, this patient goes into the left eye transient vision loss, which makes it monocular vision loss, which is a retinal event, and in the carotid circulation. So our diagnosis will be that this is retinal TIA, probably coming from the carotid. And so he did not seek initial medical attention till he developed aphasia with right hemiplegia, again showing that these are patients which are high risk and they may not seek immediate attention. So this is what we saw initially on the non-contrast CT. There's a large thrombus sitting in the left MCA. And there are some early ischemic changes in the left insula. And this is what the CTA showed. There's a thrombus in the left M1. And there's also a thrombus at the left carotid bifurcation, which is actually a source for this embolus. And this is just to show follow-up MRI. And now you can imagine if this patient was presenting after the retinal event, you could have saved all this damage and the cost of the stroke. And so this patient was started on dual antiplatelet and was referred for urgent carotid revascularization. Now, this patient is a bit tricky because there's a presence of thrombus, and how best to manage is presently unclear. This is some of the work which we published recently discussing that what are the different categories of carotid patients. And again, people are welcome to kind of read these two articles, and this was based on survey, and it's very qualitative research, which is not very common in the stroke world. So just to show that there are a lot more nuances to this, and but we can determine, and I'm happy to answer any question as how to manage this intraluminal thrombus at the bifurcation. But these patients should be started on dual therapy and referred for urgent revasc. And so he was started on the dual antiplatelet therapy and statins. He recovered well. There was a lot of other issues, which I don't think this is very relevant because it's more of a follow-up and further management. So I'm happy to stop here and take some questions. And
that's a great idea. Thanks, Dr. Singh. There are some questions in the chat, so I'm just going to read out the first one for you. What are your thoughts on operationalizing the new TIA definition in patients presenting after symptoms resolved? In the ED, these patients often do not receive perfusion, CT, or MRI.
Right. Yeah, so that's, I think, very relevant question, and because the chances of picking an ischemic lesion depends on the modality which you're using. Now, the perfusion may or may not be very relevant because even if you have a perfusion changes, that may or may not lead to subsequently tissue damage, and therefore an abnormal perfusion does not always reflect infarction. The MRI, yes, the MRI is much more sensitive, and but unfortunately, the access to MRI is not very good, especially if we are considering the entire Northern Ontario. So I would say we would still have to limit ourselves based on the infarct detected on CT. I know that there will be a lot of undercall, but at least it rules out any sizable infarction, and therefore that's a good start. But absolutely agree that if you do a lot more MRI in these patients, you will see a lot of these patients will be reclassified into minor stroke category. But as far as the management is concerned, what is interesting is that it does not overall change our managed algorithm, because the high-risk TIA minor stroke, the approach is fairly similar. It's only the presence of larger infarct that we might have to delay sometime anticoagulants, or we may not be able to use dual antiplatelet therapy, but chances of that leading to a larger stroke, leading to a very like transient symptom is quite low. And usually the transient symptoms in the presence of infarction is in the setting when the infarcts are very small. And that does not really change your safety in terms of starting the anticoagulation or antiplatelet therapy.
Thank you. Second question is, are there any role for carotid Doppler for lower risk patients, given overall increasing demands for CT angiography in the ED patients and pushback from radiology?
Yeah, so I think, again, that is a very relevant question. And I do agree that we have to do due diligence in terms of making sure that this is a true TI event. And as you can see, and if I go back, most of the time, if you really use this on a regular basis, you will realize that inclusion, and this is the exclusion, in most settings, you will not end up doing CTA if you are able to convince yourself that this is not a TIA. So, and that might be another situation where you would want to refer these patients to your local stroke prevention clinic, who can then arrange an MRI and further provide diagnostic clarification. So I think adding Doppler does not really change, because if you're suspecting TIA and you are trying to risk stratify and clear out the etiology, then most of the etiology actually lies in the head. So you will not get the answer in most of the time. So although it's more of a screening tool, and now the interest in using Doppler as a primary modality for assessing a TIA is very small. And I would say in Europe, where most of the centers use, they combine a Doppler with a transcranial Doppler, so that they have assessment of the extra and intracranial circulation. So I would say the low risk patient, I would rather refer to clinic rather than just ordering the Doppler.
Great. And just to close, there's one final question. Imaging is not always an option for the northern communities, like far north, with a significant delay to access. How should we proceed to encourage the remote north staff on how they should be proceeding?
Right. I would say that partly depends on, again, the geography. I would say if the patient is fulfilling the definition of high-risk TIA minor stroke, this cohort, I would definitely send the patient for an urgent imaging. If the patient is following into the low-risk TIA, in that setting, that's where the confusion is as to what is the best way. And I think in those settings, we do have even the support from the best practice recommendation that we can delay. And it's not an urgent or immediate, and these patients can be referred to the local stroke prevention clinic. And again, the access is quite variable, even to Doppler. So again, every center will have to kind of use their own resources to figure out what is the best way and optimize them based on the approach we just discussed. There's no easy answer to this question, and I would say it'll depend on the setting and the access and how far that is and how quickly the things can be done locally. So I'm happy to get involved if to develop any local, or Dr. Hassan, if it is in the Northwest, can help in terms of setting up or streamlining the workup pathway.
Very good. Thank you. So we're just a couple of minutes over, but great presentation today. Thanks to Brett, Dr. Kwan, Dr. Hassan for the first half of the presentation, and of course to Dr. Singh for the second half. It was all quite interesting. Might be a start to further knowledge translation across the whole entire North, working together with our colleagues from Northwestern Ontario and Northeastern Ontario. Quick reminder that the evaluation link is back in the chat. If you click on it, it'll just take you 1 minute. Help us devise our plan for moving forward with further education. Thanks for joining us today, and I hope everyone has a really great day.